Okay, so just so everyone knows, this is now being recorded. So I just wanted to talk a little bit about Dr. Curnyn and her experience right before we get started. Dr. Curnyn is a board certified surgeon and ophthalmologist. She's also a clinical assistant professor of ophthalmology at University of Illinois at Chicago, a teaching resident at Rosalind Franklin University, and a professional affiliate with Ann and Robert H. Lurie Children's Hospital of Chicago. And she's also an actively practicing ophthalmologist and ophthalmic surgeon with Suburban Associates in Ophthalmology, which is actually how Dr. Curnyn and I know each other because I worked as a receptionist over there for years. She also completed her undergraduate degree in biology and theology at Notre Dame and her MD at the University of Illinois, with her internship as a general surgeon, as well as her residency in ophthalmology at Rush Presbyterian St. Luke Medical Center. She also completed her residency in pediatric ophthalmology at the University of Illinois. Dr. Curnyn's specialties include laser-assisted cataract surgery, pediatric eye conditions, double vision, and strabismus, which is eye muscle surgery. Dr. Curnyn also serves as the co-director and owner of the Nelson Curnyn Free Eye Clinic in India, which provides charity eye care and surgery to the needy of India. So without further ado, I'm going to turn it over to Dr. Curnyn. Thank you for being here with us tonight.
Oh, and thank you, Jennifer. I was so excited to have this invitation. One of the things that I love the most is really working with patients and educating them about their vision. So I put together a series of slides that are going to cover about 45 minutes, and I'm going to talk about the front of the eye to the back of the eye, because when you think about it, the visual system really is integrated from the front of the eye with our eyelids all the way back to our brain. And I want you to have an appreciation for how they work together and what we can do to keep this visual system of ours healthy. So we're going to start with the first slide. And I just, Jennifer did a beautiful job introducing me. Sometimes I forget all the levels of education that it takes to get where we as eye doctors are. But I think one of the most important part about ophthalmology is we do go through medical school and we tend to think of the eyes as a part of our body and the overall body. So next slide, please. So what we're going to talk about is the goals. And I've got a lot of goals for the next 45 minutes. I'm going to take you through how eyelids function, how it affects the cornea or the outer surface of the eye, how the inside of the eye, iris, the opening and closing colored part of the eye works, the lens of the eye, that's where cataracts develop. We'll talk about the vitreous in the eye, that's where floaters develop. Then we're going to end up talking about the retina, optic nerve, and brain. But I want you to think about this as an understanding as a system and not just really individual parts of the eye. So we'll go to the next slide. And if we can advance, Jennifer, perfect. And so part one, we're going to start with the eye diagram. Now, this is a busy diagram, but the reason I wanted you to look at this one is it really shows how the eyelids act as windshield wipers to the eyeball. And that's why many times when we discuss vision, we forget to talk about the eyelids. But if the eyelids are not functioning properly, it's almost impossible to get the highest quality of vision into the eye. So we'll go to the next slide. We all are used to thinking about our eyelids as basically the outer surface where our eyelashes grow, obviously. But I want you to think about eyelids as almost a windshield wiper. And we know that the eyelids open and close with our blink reflex routinely. And it's that opening and closing that distributes the natural tear film over the surface of our eyes. And I want you to think about how windshield wipers work. If there's warpage along your wiper and it's moving back and forth on your windshield on a rainy day or an icy, sleety day, you're going to have areas of your vision that are cloudier and or clearer than other areas of your vision. And so we always pay attention to how the eyelid is functioning. There are plastic eyelid procedures that can tighten the eyelid to make it function as a better windshield wiper. Or if we find as we get older that the eyelids actually start to lose their muscle tone and they literally sag and cover the center of our eye, the pupil, and blocks our vision, then we can raise those eyelids up again so that they're not obstructing our vision. Many people will tell me that sometimes they'll be watching TV at night and they actually lift their eyelids up and they feel like they see better. And that is a common thing as we get older, because you think about the weight of the eyelid pushing against the eye does distort the vision a little bit. So if you notice the appearance of your eyelids changing, feel free to discuss it with your eye doctor. We'll go to the next slide. One of the things that we've been learning about is the actual glands that are next to your eyelashes. And I know this might seem small to you, depending if you're on an iPhone or an iPad, but over the past 5 to 10 years, doctors are really investigating how the oils that come from the oil gland next to every single eyelash. So when you think about it, you have 50 eyelashes across the upper lid, 50 eyelashes on the bottom lid. That means you have 50 oil glands on the top, 50 oil glands on the bottom that are constantly releasing oils over the surface of your eye. And again, oils are wonderful because they can sort of hold the natural tears on the surface of your eye. But if you get too many oils and the oil tear film ratio is affected, then your vision will be blurry. So about 3 to 5 years ago, there's many doctors that are recommending that patients treat overly active oil glands on the eyelid before they even have cataract surgery, because they feel that if you don't have a perfect surface on the cornea, meaning you've got the right balance of oils and tears, that your vision will not be optimized after the cataract surgery. There's even centers that offer a procedure called LipiFlow, where they heat the oil glands along your eyelid so extra oils drain out. I personally feel you can get a very similar effect by being diligent every night, taking a clean washcloth, running it in as hot of water as you can tolerate out of the tap, hold it over both eyelids and count to 50. This slow type of periodic warm compresses every night will ensure that the oils do not build up and become out of proportion to the natural tears on your eyes. We'll go to the next slide. Now, when you look at the clogged oil gland, this is what many of us see and know as a stye or a chalazion. And what this is one of those tiny oil glands that's next to an eyelash had become clogged up because either the skin was dry along your eyelashes, maybe you were rubbing your eyelid with dirty hands and bacteria got in there, but then the oil gland became filled with bacteria. And there's been 2 papers published in this past year since COVID saying that primary care doctors, pediatricians, optometrists, and ophthalmologists are seeing more and more of these clogged and infected oil glands since people are using masks full time. And when you think about it, it makes sense. The bacteria from our breath in our mouth blows up under the mask to our lower eyelids and clings to those eyelashes. So again, a very good routine to get into is nightly warm compresses to open up those oil glands so they don't get infected. Another routine I recommend many people to start is when you shampoo your hair in the shower and your fingers are sudsy. And I'm hoping you're using a gentle shampoo, such as baby shampoo or something with low pH from Trader Joe's. But then as your fingers are sudsy, you can shampoo off the eyebrows and the eyelashes to ensure that there's no bacteria buildup or dandruff type buildup along that. Now we're going to go to the next slide. And we're going to discuss the cornea. The cornea is the next layer under the eyelids. Many people talk about it as the window to the eye. It's the clear surface. It's the most outer surface of the eyeball. And this is where your contact lens would rest. Or this is where an injury from a fingernail scratch, mascara wand, somebody rubbing their eyes too hard, or people working around dusty or rusty metal, and those flecks fall into the eye. It clings to this outer windshield of the eyeball. And anything that disrupts this pure, clear surface will affect your vision. We know your eyelids, if they release too many oils, can disrupt your clear surface, but we also know scratches on the eye. And we can go to the next slide. And this will show you the example of somebody that has a corneal abrasion. And this will show you how if that outer clear surface becomes disrupted, either it has a scratch or something caught on the eye, your clear view to the world is affected. This is what we see when we test with a fluorescein on somebody who's had a corneal abrasion. Now, luckily, the outer surface of the eye, the cornea, tends to heal quickly. It can heal in 24 to 48 hours. And so it's got wonderful regenerative processes. Now, if it's unable to heal quickly, then we suspect a nerve damage to the cornea. And that would be something your doctor would talk to you about, because there is a new medication that has come out that you can use for a 6-week period that would help the nerves regenerate and heal corneal abrasions. Let's go to the next slide. The next slide is an example of a cloudy cornea. And I don't think my slide showed up, but I was going to just tell one more thing about cloudy corneas. Cloudy corneas can come from something called Fuchs Dystrophy. Fuchs Dystrophy is something that many of my patients have been told they have, and they're concerned. And I always reassure them that Fuchs is a descriptive term of the inner layer of the cornea that is composed of pumps that keep the amount of clear water interacting with the surface of the eye. And as we get older, sometimes those pumps wear out, and it's called Fuchs dystrophy. And there's several surgical procedures that can repair and restore that inner lining of the eye so the pumps can allow you to have a clear cornea again. We'll go to the next slide now. And the next slide, we'll be talking about the iris. I want to see if that shows up. There we go. And so we'll go to the next one. And the iris is the colored part of our eye. And I think it's having a hard time keeping the slides loading. The colored part of the eye is what we identify with on our driver's license. We talk about, you have a blue eyes, brown eyes, green eyes. And when you think about it, our eyes are depending on the number of layers of pigment on the colored part of the eye. So most children are born with lighter eyes, and many children have those bright blue eyes. And parents always want to know, what is the real color of a child's eye? But many times we really don't know what the color is until the babies are about a year old. And that's because the original layer of pigment can build up, and you may have 2 or 3 layers of brown pigment over the original blue eyes, and we call that green eyes. Or you might find there's 6 layers of pigment, which make the eyes of a more hazel or golden color. Or you might have 8 layers of pigment, which would lead to a definitive dark brown eye. So the iris will open and close depending on the amount of light. And it works very much like a diaphragm this is the picture that Jennifer's showing you is a great one, showing a young child with the blue eyes. You can see that extra layer of brown. And depending on how open or closed the iris is, the eyes might look more brown in certain lighting situations, or clear or more blue in other lighting situations. We can go to the next slide. Now, the doctors always talk about the pupil, and the pupil is in the middle area of your iris. The iris is the colored part. The pupil is the opening in the middle of it. And you will constantly be asked if people have head trauma, what do the pupils look like? And we become concerned if either both eyes are dilated and do not react to light, or we see an asymmetry, like in this example, where one pupil is larger than the other pupil. And so many times family members may bring it up and notice if somebody's pupils are asymmetry or asymmetric. And if it persists, we definitely want you to tell your primary care doctor or your ophthalmologist so we can find the cause of this asymmetry. More recently, we have seen more young adults coming into the emergency room with this type of picture where one eye is dilated and the other eye is not. And we found that it was linked to a new antiperspirant that is prescribed by dermatologists. And what you're supposed to do is use this type of deodorant. It comes in pre-moistened towelettes. You wipe it under your armpits so that you don't perspire throughout the day. And then you're supposed to wash your hands after you throw the towelette away. But many young adults are on a busy day. They put the deodorant on and then they forget to wash their hands and they wipe their eye. And this deodorant can actually dilate the pupil. So now, and we hear somebody has 2 different size pupils, not only do we ask about headaches, migraine, but we also ask if they've used a new type of deodorant. We also ask if they've ever used a scopolamine patch, because that can lead to 2 different size pupils. We can go to the next slide. Another thing that you can find is if the pupil is not round, it's very irregular. And this is a sign of inflammation occurring in the eye. So patients that have certain type of arthritis problems, they have certain type of autoimmune problems, where they can get something called an iritis. And I always tell my patients, we hear the term arthritis, which we know is inflammation in a joint. We hear the term otitis, which is inflammation in your ear. We hear colitis, which is inflammation in your colon. But you can also get iritis, which is inflammation in your eye. So if you ever notice your pupils looking irregular like this, again, notify a primary care doctor or your ophthalmologist so they can investigate if you have a type of joint problem that can lead to this. We can go to the next slide. And with the next slide, we're going to be talking about the lens inside the eye. Here's another beautiful picture of an eye. You see the normal eyelids that are like flush against the eyeball. So the windshield wiper is working good. You see this beautiful clear cornea, that glass layer, and it's so shiny and it's reflecting the light. So we know there's a perfect balance of tears and oils on the surface of the eye. We see the iris has a round opening, so we know the pupil is fine. There's no inflammation. And we see in the center of the pupil a very dark, clear area. So we know nothing is obstructing the light rays going into the eye. We can go to the next slide. Now, if there's development of obstruction into the eye, that's when we hear the term cataract. And many of my patients always ask where a cataract is. So if you look at this diagram, you'll see on the far left is the diagram of the clear cornea. You'll see the brown tissue next to that, which is the iris. And directly behind that, you'll see that oval shaped bluish material. That is the lens that you're born with. And the lens that you're born with is crystal clear. And as we age, that lens becomes a little more yellowed and a little more cloudy. And you could see as light rays are entering in the eye, if that lens is not clear, it's going to limit your perception of the world. And we can go to the next slide. And this shows you what a cataract looks like. Here, the pupil is dilated. And instead of being black in the center, do you see how yellowish and cloudy that center of the material is? This is a patient that has a cataract. So when the light rays are trying to shine through this tissue, you can imagine that it's limited on how much can get into the eye. And one of the things that many people with this type of cataract notice is that they don't see blue at the same level or quality that they did years before. And I often use the example of the women in the 40s and 50s that they would say the blue-haired women. And the women were using a whitener on their hair, but because they had cataracts, they couldn't see when there was a blue tint to their hair. So many of them, looking out of their lenses that were yellow like this, thought they had snowy white hair. They didn't realize they had too much bluing on their hair color. Another example of somebody who was looking at the world through this type of cataracts was Monet. Monet had the blue period. And you remember, if you look at paintings from that time, how heavy he was in using blue pigment. And that's because he couldn't see the blue, so he added more and more blue to his palettes, trying to get the effect that he wanted. Now, many patients, when you take the cataract out, will remark the next day is, oh my goodness, I'm seeing blues and whites like I never did before. Now we can go to the next slide, Jennifer. And this is what a lens implant looks like. So when we take out that yellow cloudy lens, if we don't put a new lens implant into your eye, there is nothing to focus the light rays. And traditionally, if you remember grandparents and years ago, if somebody had cataract surgery, they would have to wear a very thick pair of glasses. Sometimes people would call them Barney Google glasses, or they would think of Mr. Magoo type of glasses. But in the late 60s, early 70s, a very astute ophthalmologist in England realized he was taking care of World War II veterans who were pilots and flew missions with the plastic covering over the cockpits of their planes. And many of them, if the plastic had shattered, it went into their eyes and lay dormant for years. So this ophthalmologist named Harry Ridley said, well, if that plastic can lay dormant in the eye for years, why can't I grind that plastic to focus the light rays to help a person see after cataract surgery without wearing thick glasses? So this is what a modern lens implant looks like that we put into the eye after we take the cloudy cataracts out. These lens implants have many options now, and your doctor may ask you, do you want a lens implant that can let you see far? Do you want a lens implant that lets you see close? Do you want a lens implant that can remove your astigmatism? Or do you want a lens implant that lets you see far, medium range, as well as close range? And that is called a multifocal lens. So we've come a long way since Dr. Ridley decided to mold plastic into an implantable lens for the eye. Now I'm going to show you a picture of another type of lens implant that we use. And instead of putting the lens behind the colored part of the eye, you can go to the next slide. You can put the lens in front of the colored part of the eye. And this is called an anterior chamber lens implant. And this is used when some doctors are trying to either correct very nearsighted patients that a traditional lens implant cannot work, or if somebody does not have a good membrane support behind the iris to hold the lens. So you may hear the term sometimes of an anterior chamber lens implant, and that's what this looks like. Now we're going to go to the next part of the eye, which is the vitreous. And the vitreous starts behind where the natural lens is and fills the entire eyeball itself. And vitreous is a very thick, solid gelatin type material. I tell my patients it's very similar if you make a bowl of gelatin and put it in your refrigerator and pull it out the next day. The jello clings to the edge of your bowls, and you can move the bowl around and it pretty much stays put. But as we age, one of the most common natural aging changes that takes place is this jelly starts to become liquefied. In the same way that you would think of a bowl of jello sitting there for multiple days, it might start to contract and pull away from the edge of the bowl. And you might notice it being more liquid in some areas and thicker in other areas. The same thing happens to the vitreous inside our eyes. And that is called either a vitreous separation or a vitreous detachment. Either way, it causes people to see multiple floaters in their eyes. And when it's just the jelly that is liquefied, many times the floaters look like shapes of amoeba or gray lines moving around. You might notice that if you're looking at a clear blue sky or a white wall in your house, that if you move your eyes left, right, up, or down, that you'll see these sort of gray shapes move around as you move your eye. Those are normal age-related floaters. Many highly nearsighted people may start seeing their floaters in their teenage years. Most of us, though, will start seeing floaters in our 50s and 60s as this jelly liquefies. Now, when do we become worried about floaters? That's when the jelly separates from the back of the eye where the retina is located. And if it separates suddenly, it will actually tug on the retina. And when it tugs, you'll see sharp, bright lights many people feel like they suddenly think a strobe light went off out of the corner of their eye, or they feel like they're starting to see a light bulb flash or burn out. That means that the jelly has tugged onto the retina. Now, what's the concern? The retina is a very fragile, thin lining of our eyeball. And if something tugs quickly on it, you can pop a hole in the retina, which would cause pigment or broken blood cells to leak into the center of the eye. If that happens, you would see thousands of little black spots. They're usually black, you can't see through them, and they keep multiplying more and more and more, as if somebody is putting India ink into your eyes, and it's dropping and spreading and getting bigger. Those type of floaters and that type of flash that goes with it is considered an ophthalmological emergency. We want you to call your eye care doctor immediately, because the quicker that you can come in, let your doctor look at the lining of your eye and find where the hole is, the quicker that hole can be lasered shut or sealed shut to prevent you from getting a retinal detachment. A retinal detachment is when fluid from this vitreous, that whole, all that fluid that's filling up your eyeball, leaks into the hole of the retina. And once the fluid gets under the retina, then you have a retinal detachment. And so with modern technology, modern treatment, we feel that if we can educate our patients to report immediately when something like this has happened, we can treat the retina and hopefully avoid a retinal detachment. Let's go to the next slide. We're going to go into part 2 now, that we're going to talk about the retina itself. And I know many of the people listening on this program are most interested in the retina, because the retina is such a fragile lining of the eye and is one of the most important parts of our vision. And unfortunately, it's the part that shows the aging the easiest. So this is what a normal, healthy retina should look like when your doctor looks into your eyes. You see that lighter colored area, that's the optic nerve. And you see how gently the blood vessels spread out from the optic nerve to the edges of the retina. And then you'll see a little darker area to the right of the optic nerve. That is the macular area. That is the pigmented area that accounts for our most detailed vision. And inside that macula is a single pinpoint area called the fovea. And the fovea is what gives us our sharpest 20/20 vision. Now we'll go to the next slide. I tell many patients the retina is very similar to our skin. And in the same way, we notice that our skin starts to get age spots. We start to get some areas that are darker than others, some areas that get lighter than others. Basically, our complexion on our skin shows signs of aging. The same thing can happen in the retina. We will start to get literally a loss of pigmented cells in one area and then extra pigmented cells in another area. Once we start to see these age spots, we are diagnosing something called macular, because it happens in the macula, degeneration, meaning the pigment of the macula is starting to degenerate. Now, unfortunately, this usually results from years of sun damage. And if somebody was a cigarette smoker, then use of nicotine can make the situation worse. But sometimes individuals will just be genetically predisposed to it. So this is something we really want to monitor closely when you're over 65. Now, can we reverse the damage in the retina? No, but we can help stop it from degenerating any further. So if a doctor starts to see changes in the retina, one of the most common things they'll tell you to start doing is to take a multivitamin. And I know for years, doctors said vitamins don't really change much, but this is one situation where they did a randomized study and they took 6,000 individuals and told them not to take vitamins and eat their regular diet. And another group, they gave vitamins A, C, E, zinc, and lutein. And they found that the group that took that combination of vitamins actually slowed down or stopped future degeneration. Now, typically, the medical community is skeptical. And so doctors said, well, wait a minute. Can that really be true that vitamins and nutrition can slow down the degeneration of the retina? So they repeated the study. And they repeated, it's called the Age-Related Eye Disease Study 2. And it showed the same thing, that there is definitive benefits to good nutrition and nutritional support. So if you're ever at Costco or the drugstore and you see eye vitamins and they refer to the AREDS 2, AREDS number 2, then you know those vitamins are compliant with the study that was performed showing that vitamins can protect the retina. Now we'll go to the next slide. What happens if the retina continues to degenerate? And this is an example of a retina that has continued to lose pigment and continued to build up abnormal pigment in other areas. Well, this retina is starving and it's trying to help itself repair. But unfortunately, the way the retina tries to repair itself is it grows abnormal new blood vessels. And those blood vessels try to fill in the gaps of these degenerated area. And if those blood vessels break open and bleed, then we talk about wet macular degeneration, meaning that before the eye just had the age spots and it was dry, there was no abnormal degeneration. But once the blood vessels break open, then it's called wet degeneration. And that is when a retina specialist will recommend injections of anti-VEGF. It's something that will fight against the growth of new blood vessels in the retina. The most common injection you probably have heard of is called the Avastin injections. And Avastin was originally used for cancer sufferers. Colon cancer tumors would shrink if the doctors administered the Avastin. Somebody decided to think, well, if it worked for colon cancer, maybe a low dose injected into the eye could shrink these abnormal blood vessels. And it worked dramatically. So now many seniors who have wet macular degeneration go to their retina doctors every 2, 4, 6 weeks for Avastin, or now the newer type of treatment that it works on a smaller molecule would be called the Lucentis and Eylea. So I'm going to go to the next couple slides. We're going to be winding down here. I just want to show one quick example here. This is what happens when your macula degenerates. You keep your peripheral vision, but you lose your center vision. So we'll go to the next slide. This is the optic nerve. And I'm just going to touch briefly on this to show you that the optic nerve connects to the brain. It's not just an isolated part in the eye. It is your conduit. It's your cable connection to your brain. We'll go to the next slide. This is what an optic nerve looks like if there's fluid in the brain pushing against the nerve. You can see how it's elevated, it's sticking out towards the vitreous. This, if we find this, we know right away to get an MRI and to check and make sure there's no brain tumor or swelling in the brain. We'll go to the next slide. Now, this is an example of an optic nerve that's cupped out. You can see how healthy it is on the left. And then a few years later, the optic nerve became more cupped. That center area became larger. And look at the far right. The cup is so large that there's no healthy tissue connecting the eyeball to the brain. This is what happens in the cases of glaucoma. And this is why it's important to get your eye pressure checked on a yearly basis, or sometimes 2 or 3 times a year by your eye doctor. Let's go to the next slide. So again, the brain. This is sort of a futuristic image showing how maybe electronically someday we'll restore sight by having electronic connection from the eye to the brain and from the ear to the brain. But right now we've got to protect what we've had and the connections that we have. Let's go to the next slide. So this is just a quick example showing whatever vision comes into our eyeballs has to connect into the brain, and the vision component is the back of the brain. And just quickly, I want to tell you about something that can happen to patients when they have an eye migraine. So you can see that even though the light is coming into the eyeballs, it's actually the back of the brain that interprets what is going on. And if there's ever a blood vessel spasm in back of the brain, it triggers abnormal vision responses. And people can actually see images that aren't there. They might see triangles and squares or a kaleidoscope of colors. And that's because the blood vessels have spasmed. If it lasts less than half an hour, then the doctor will reassure you that's a benign situation and we don't worry about it, and it's an eye migraine. Now, sometimes people have this blood vessel spasm in the back of the brain, and then it develops in the front of the brain, and that's when you get pain in your head, and that's when you get a migraine headache. And so you have to remind yourself that the blood flow to the eyes are so important, and the blood flow to the brain is very important. So let's go to the next slide and we'll start winding down here. So how do we really protect the most important system in the body? And of course, being an eye doctor, I feel the visual system is the absolute most important. Well, number one, pay attention to your nutrition. Of course, we would rather you get nutrition by eating your leafy green vegetables, kale, spinach, salads, and fruits, and get the intake that way. Grandma was correct. Carrots are really good for your eyes. But if you can't keep up good nutrition, please take advantage of the multiple vitamins that are out there that adhere to the ARADS2 formula. The next thing is we have to pay attention to protecting your eyes. We know that we should be protecting our eyes from sun damage, but really we should start protecting our eyes from sun damage when we're children. So I want you to encourage your grandchildren and your children to wear sun protection, protect those eyes. I also encourage protection from any kind of trauma. I think it's very important that we have to remember, put on those safety glasses when you're working on your car engine, when you're working around the house doing small projects. Take care of them. The other way you can protect your eyes is think about protecting them from drying out. Restore that perfect oil-water balance. Use artificial tears. Another thing we have to remember, because the eyes and the body are so closely connected, exercise. We talk about exercising your eyes by taking a break from your computer every 20 minutes, look 20 feet away for at least 20 seconds. That relaxes the inside muscle that focuses in your eye so that you don't tire it out and get symptoms and headaches. Exercise in your body, it's been well shown, increasing your cardiovascular work helps the blood flow to the eyes and the brain. Hygiene. It sounds simple, but literally washing your eyelids. Think about it the same way you would not go too long without washing your scalp and hair with shampoo. Make sure you're washing your eyelids and your eyebrows so that oils and bacteria don't build up. Yearly eye exams are crucial to check in, see what your vision is, check your eye pressure to make sure you're not getting glaucoma, looking for any age spots in the retina so you can start to be proactive in treatment. Do your yearly medical checkup. You've got to remember that every time your blood sugar is out of control or your blood pressure is out of control, you're putting stress on those blood vessels inside the eye and stress on the blood vessels inside the brain, and strokes and complications from too high of blood sugar and blood pressure can damage your vision permanently. Finally, I want you to start to educate yourself. Logging into programs like this is crucial. You'll know the questions to ask your doctor next time. You'll know what to pay attention with your eye health. And I want to remind you that home testing is possible. There's an app, and we can show it on the final slide, and then we'll switch to questions. It's called the Eye Handbook. It's a free app. You can download it, have your kids download it, have your grandkids download it. But it's a free app that shows many of the tests that we use in the office. You can test your actual vision. You can check your color vision. You can check an Amsler grid, which is a grid type printout that tells us if you're starting to get macular degeneration. So I would encourage everybody to get the Eye Handbook. It also has an educational component so that if you get home and your doctor said, oh, I think you're getting cataracts, you can look up and see what cataracts are and educate yourself. So the next time you see your ophthalmologist, you can ask them about it. So thank you so much. We can go to the final slide. And then Jennifer, if you have some questions that you think might benefit everybody, I would love to answer them in our final 6 minutes.
Okay, thank you so much, Dr. Curnyn. I do have a few questions for you, but
Okay.
really quickly, I meant to send this right at the beginning and I forgot. It's just a quick poll, if you wouldn't mind answering it, just so we can see how many people are here tonight. And we'd also like to see how many of you actually see an ophthalmologist as well. So if you wouldn't mind answering that, based on your answers, we're allowed to offer programs like this here at the library and bring in great people like Dr. Curnyn. So we had a lot of questions about vitamins tonight. So some people wondered, first of all, is there a particular brand of the AREDS too, and where you would buy it? And then also what age you would start taking those at?
Okay, that's very good questions. So the original recommendations by the FDA was, if you started having signs of these age spots, your doctor told you they started seeing them, start the vitamins then, because they really didn't have a controlled trial to say how beneficial are they when you're younger before the degeneration has started. So what I discuss with my patients, I think you can start the AREDS formula vitamins as young as you want, but I always keep in mind, are you young enough to tolerate a good diet of leafy green vegetables and fruits to supplement the good nutrition in your body? Because one of the problems with a lot of our seniors are they're on Coumadin they can't eat leafy green vegetables, or their doctors warn them against it, or their digestive system can't tolerate the fiber that comes from that. So for a lot of my seniors, I'll say, definitely, if you can't keep it up with your actual diet, start the vitamins then. For younger patients, if you've got a good nutritional diet, then I think you're fine waiting a little bit longer on the vitamins. But again, there's no downside to it.
Okay, perfect. Then I had another question. What is the cause of dry eye and what can we do for it?
Okay, dry eyes is a very frustrating phenomena that happens usually in our 40s to 60s. And in the very original diagram that I had of showing the eyelid, that under the upper outer corners of our eyelid is a gland on each side. Sometimes you can feel it, and it's called the lacrimal gland. And that gland secretes two kinds of tears. It secretes a very thick cushioning tear, as well as a thin, very thin reflex tear. So I always tell patients the gland should be producing the thick tears, but unfortunately, as we lose estrogen levels in our bodies, we don't create those thick tears. So a lot of times we're just left with those thin, drippy tears, the kind of tears that you get if you cut an onion and suddenly they just run down your face. And a lot of my seniors, I always see a little Kleenex tucked up their sleeve because they don't have the thick cushioning tears because they're postmenopausal or they're over 80 and their lacrimal gland just can't make the same amount of tears. So they just get the thin, drippy tears. That's why we recommend using tear replacements and like a thick gel tear that can replace the ones that your body's not making. And then another problem is those oil glands. You got to imagine if your body's only cranking out oil, it's repelling those few little tears that you have. So you've got to do those warm compresses to bring the oils and the tears back into balance. I hope that helps.
Thank you. I was going to say too, I don't know if you mentioned, but Refresh, I know, is the brand that we often
yes,
promote at our practice. So I'll put that in the chat for people, and that
Uh-huh.
it's artificial, non-preservative tears.
Correct. The problem with the preservatives, they're great if you only use your teardrops a few times a week. But if you're using teardrops every single day, 3 to 6 times a day, then you want to use something that's preservative free so that you don't become allergic or irritated by the drops that are supposed to be helping you feel better.
Okay, perfect. In regard to artificial tears, I have somebody asking how many times a day is appropriate.
I think it's what your living environment is like. If you're somebody that's outdoors on windy days, gardening, and the wind is blowing, and that you might want to use your teardrops 4 to 6 times a day to replace what the environment is taking out. Now, if you're a snowbird and you're down in Florida and it's hot and humid, you might get by just using your teardrops 1 to 3 times a day. I always tell people the minimum that's probably going to give you some relief is if you use it every morning when you wake up to replace the tears that you lost while you were sleeping, that they evaporated off, and then at night before you go to bed to give yourself a good cushioning before you're sleeping. Things like a hot, steamy shower help in the morning, and a humidifier running at your bedside during the winter helps at night.
Okay, perfect. A couple more, if you don't mind, if you have to leave, I totally understand anybody.
No, I'm just excited. I'm excited people want to hear this.
Okay, so how do you feel about the multifocal IOL lenses for a patient needing cataract surgery?
Again, I think it's a great lens, but you have to be the right candidate for it. You do not want to get a multifocal lens if you have age changes inside the retina, because all the multifocal lens is going to do is sort of magnify those distortions, that irregular area in your retina. So one of the most important thing is make sure your doctor checks and examines your retina closely with something called an OCT to make sure that your retina is healthy enough to handle a multifocal lens. The other thing is the multifocal lens is designed with rings stamped into it. So that can cause glare and halos at night. So if you're a senior who decides to get your cataracts out because you're having difficulty night driving and it's the glare that's bothering you, there's going to be an adaptation period because the multifocal lens also gives you glare. Now, the good news is you usually adapt to it after 3 to 6 months, but it's a frustrating adaptation period you have to go through. So I find the people that do the best with the multifocals is somebody whose sort of lifestyle demands that they go between 3 ranges of vision. So a lot of our senior executives, they might be in their 50s, early 60s. They are still traveling. They might have to see, a distant billboard and, the dashboard and pick up an iPhone while they're in traffic, which they shouldn't be on phones, but whatever. They need that kind of range of vision all the time. Some of my seniors who are still very interested in multiple activities, they're still working on the computer a lot, as well as looking at distance targets. It works, but I think it's something that is made for a very healthy eye that does not have glaucoma, that does not have macular degeneration, and you've got to be just the right candidate with correct expectations.
Okay, perfect. Let's just do one more question before we leave. And if you didn't see your question answered, I am going to actually direct those questions to Dr. Curnyn, and I can email everyone with those answers. And they come back. I'm also, if you needed a question answered and you wanted me to direct them to Dr. Curnyn, I'm going to put my email address for you right now. So you have that as well. The first link that I put in the chat is Dr. Nelson and Dr. Curnyn's charity in India, if you want to check that out to see what she's doing there. The second is the practice that Dr. Curnyn is currently out of. And then the next 2 links are about a couple of programs that you might be interested about signing up for Medicare or any information regarding that, are the next 2 links in the chat. So for our last question, are there any regular eye exercises or websites you can recommend to maintain good eye health?
Okay, that's a very good question. I don't have any websites I can think of right now. The broadest consensus across the world for what the eye exercises are the near to distance break time, because staring only at close-up activities has been well proven to be fatiguing to the eye, and it can actually cause more nearsightedness in our young children. So that's why young children are now instructed to at least spend an hour a day outdoor activities looking at the horizon. Now, the eye muscles that move your eyes left, right, up and down, and that's an interesting phenomenon that ties more into yoga type exercises, because we do know any muscle in the human body will contract if it's not utilized and stretched over time. So many times, most of my patients who do an eye exercise that we think about, that you would do a yoga exercise, it involves looking as far to the right, as far to the left, as far up as you can, as down towards your toes, up into the upper right corner, down towards your right shoulder, up into the left corner, and then down to your left shoulder. And many times my patients find more of that information through yoga type relaxation meditation literature, not medical literature.
Okay, perfect. Thank you so much for being here with us tonight, Dr. Curnyn. And thank you all for attending. Your attendance here lets us offer programs like this. So thank you so much for supporting the library, and thank you, Dr. Curnyn, for coming tonight.
Thank you all. And thank you, Jennifer. I really appreciate the invite.